Hi everyone, in this lesson we're going to go over low-level light therapy, or laser as it's referred to a lot clinically. This is chapter 19 in your book, and again what we're talking about is light energy. Light is a form of electromagnetic energy, and it is the most abundant energy form in the universe. It's why you're seeing people go around and trying to put solar panels on their houses and using solar energy and things like that. And we can use it for some therapeutic purposes as well. So there are three general classifications of light. Ultraviolet, you've heard of UV rays from the sun, visible light, and infrared light. And laser can come in any of those categories. Lasers are going to produce highly refined, which means they're very focused, right? That was the whole big thing with laser pointers. You can stand across a room and shine a laser pointer and it stays a very small dot, as compared to shining a flashlight where it sort of expands and makes a much broader range. Monochromatic means it's all the same color. So a laser is typically one or two colors that we see therapeutically. Red or blue are usually the ones that we see, and it's all the same color. And again, it can be in the ultraviolet, visible, or infrared range. This was something I learned when we added this chapter into the book, that laser is actually an acronym. It stands for Light Amplification by Stimulated Emission of Radiation. So that's where the term laser came from. Laser uses highly organized light, or sort of packages of light called photons, which can cause some physiologic changes in the tissue, and that's where it comes into play therapeutically. Low-level light therapy, what we have in the clinic, does not cause tissue destruction. When you think of laser surgery, you think of like laser eye surgery, things like that. That actually causes tissue destruction and changes that way. Our lasers that we use clinically are not that powerful. And there are a variety of conditions that we can use laser for. So if you look at this picture, this machine should look kind of familiar to you guys. We have one of these machines, and you've used one of these machines for ultrasound and for electrical stimulation. So if you look at this machine, this is your ultrasound head. On this side, over here, this would be your laser head, or your low-level light therapy head. And it looks very similar to another ultrasound head. I'll talk a little bit more about this later, because we do not have a laser that we can use in the lab, but it is very similar. The only difference is right here on top there's a little push button which starts and stops your laser. So other than that, we can discuss some of the settings on the machines if you do want to take a look at those. So energy from laser is produced in wavelengths of 650 to 1200 nanometers. You don't need to memorize that, but do know that wavelength is what's going to determine the color of your laser. Like I said, most lasers that you're going to see clinically are probably going to be red. There are some blue lasers out there as well, and that's a difference in the wavelength of those two types of lasers. So photons, again, are those packages of light that are going to be emitted during the laser treatment, and they activate skin receptors. And then that's what causes the physiologic events that happen following application of laser. What is actually being activated are chromophores, which are your melanin, which is what causes the pigment in your skin, and your hemoglobin, which is your major transporter of oxygen. They're going to absorb specific wavelengths, and then they're going to have effects underneath the surface. Hot lasers are class 4 lasers. Lasers are graded in classes from 1 to 4. 1 would be not a whole lot of light, minimal damage. 4 can cause some significant tissue changes, right? So hot lasers, class 4 lasers, this is what physicians use for surgery. So for eye surgery, wrinkle tattoo removal, even like the capsular shrinkage, sometimes we see that in the shoulder. We'll talk about that more in Therax next term when you hear about capsulorrhaphies. That's shrinking of the capsule itself to provide more stability at the shoulder. So those would be class 4 lasers. That's not what we have in PT. We typically have somewhere in the class 2 laser range. So other forms of light can include superluminous diodes and light-emitting diodes, or LED lights. A lot of the lasers that we have, and the one that would come with that green Dynatronics machine that we just talked about on the previous slide, actually has a combination of some laser as well as some superluminous diodes as well. So lasers, again, produce refined homogeneous beam that's characterized by 3 features. So as we mentioned earlier, they're monochromatic. So all the light that's traveling within that laser is of the same wavelength, so it will all be the same color. It is coherent, that the waves are going to travel in the same phase, and it's collimated, which means it doesn't diverge or spread, like we used the example of the laser pointer versus a flashlight shining it on a wall. So lasers are classified, again, based on a power level of 1 to 4, where 1 is really minimal, no damage. 4 is going to be those hot lasers that doctors use for tissue destruction or alteration. Low-level light therapy typically uses class 2 or class 2A lasers. The output is fairly low. It doesn't usually exceed 1 milliwatt. And 2A lasers and above have to be labeled with "do not stare into the beam." Just to give you a comparison, barcode scanners at the grocery store are 2A lasers. So we're not getting too much more powerful with our therapeutic lasers. Typically what you'll see in the clinic, again, is 2, maybe even a class 3. Anything class 3 or class 4 lasers, both the clinician and the patient would have to wear protective eyewear or goggles. One of the biggest benefits of low-level light therapy is that it doesn't cause significant thermal changes. So what happens is, again, this series of photochemical events that happens underneath the surface after the absorption of the light, we are going to be able to see an increase in local circulation, but be able to do it without the thermal changes. So that is probably the biggest benefit of using laser over some of the other modalities that we have. The tissue reaction is going to be based on the frequency and the wavelength of our particular type of laser, the power density, the duration of treatment or how long each treatment session lasts, the vascularity of the target tissues, which we don't have much control over, and the skin's melanin and hemoglobin content, which again, we also don't have any control over. So it is this absorption of photons or light that is actually the direct effect of laser. But then again, the indirect effects, which are chemical events that caused by the absorption of light, are found deeper down into the tissue. It is dependent on the wavelength of your laser, and longer wavelengths are going to penetrate deeper into the tissue than shorter wavelengths. And low-level light therapy can get to about 2 centimeters by the indirect response. The direct response is even more superficial. So it is a very, very, very superficial modality. So this is a helium-neon laser. This would be what the laser head would look like from that green Dynatronics machine. So if you pulled it off the unit and you flipped it over and you looked at it, this is what it would look like. They are red lasers. And these couple little points are going to be your laser points. There are other little dots in there. Those are typically your superluminous diodes. So it is a combination of both types of light therapy. The maximum output for these is 1 milliwatt or less. So they are on the lower end of the lasers. They can penetrate 0.8 to 15 millimeters deep. Remember, millimeters, 10 millimeters make up a centimeter. So this is very, very superficial. Again, those indirect effects are going to be deeper. These aren't in every clinic because they are expensive. So some places you might go, you might see some of them out there. Other places you may not. There are a couple of other types of lasers. Where I did see some helium-neon lasers, but there are a few other types as well. Gallium arsenide layers penetrate a little bit deeper, have a little bit higher output, up to about 2 milliwatts. And they are delivered at a lower average power. So they're actually able to deliver a decent amount of energy without as much power. There's also gallium aluminum arsenide lasers, which have a much higher output. They do use multiple diodes, and they are able to get a little bit deeper with their penetration. Dosage is the amount of energy that's actually going to be delivered to the tissues. It's expressed in milliwatts per centimeter squared, and for lasers, we'll use joules per centimeter squared. So that should look a little familiar, right? With ultrasound, we talked about watts per centimeter squared, so it's based on the treatment area as well. So there's a whole formula there. You don't have to memorize it. I'm not going to give you any math problems with that, but do keep in mind this is going to be a dose-oriented treatment based on the area that we're treating. So a treatment dosage of 5.0 joules per centimeter squared with an output of 1 milliwatt over an area of 1 centimeter squared would be about 50 seconds. So when we go, if we look at the machine, most of this is going to be pre-programmed for you when you choose your output. Common clinical dosages are going to range from 0.5 all the way up to 10 joules per centimeter squared. So again, somewhat similar to ultrasound in that we started on the low end at 0.5 watts per centimeter squared, but we typically maxed out at 2 or 3 watts per centimeter squared for ultrasound. For laser, we're able to go up a bit higher when we're talking about joules per centimeter squared. So as far as response on the injury response process or the effects, again, it's these photochemical or photomechanical effects that are happening indirectly underneath the surface that is giving us the therapeutic benefit of using a laser. The first law of photobiology, and apparently this is a thing, but for light to affect tissue, it has to be absorbed by specific receptors or it has to be absorbed by the tissue. So for us, the primary photoreceptors are going to be hemoglobin, COX, myoglobin, and flavoproteins. Hemoglobin and myoglobin are going to be your major carriers and storers of oxygen. COX is an enzyme that contributes to inflammation and pain. In fact, non-steroidal anti-inflammatories like ibuprofen, Advil, things like that, those actually work to inhibit COX. So COX is going to promote more inflammation. We typically try to calm that down. Flavoproteins are also enzymes that are going to be affected by laser as well. So the energy that is absorbed by the light is going to affect mitochondria, which are, remember, our cellular powerhouses. That's going to stimulate the production of ATP. With the production of ATP, we can have alterations in molecular level activity. It can stimulate the electron transport chain. It can increase the production of ATP or local energy, so increase local metabolism. It will reduce local pH and reduce COX production. So again, remember, COX contributes to pain and inflammation, so if we can calm that down, we should hopefully help to reduce pain and inflammation as well. Laser has been theorized to affect pain-producing tissues, such as muscle spasm, by helping to restore normal function by increasing ATP and different enzyme activity. So laser or low-level light therapy can produce anti-inflammatory effects. We'll see that along with fibroblastic stimulation occurs most at 2.5 to 5 joules for treatment, but then it's actually inhibited. Fibroblastic activity is actually inhibited if you get higher, much higher than that, 7 to 14 joules. Those gallium arsenide layers can produce muscle healing, and helium-neon lasers, again, the kind that you would probably be most likely to see, that were applied 2 days post-injury and applied every 2 days, were found to promote healing better than placebo. So there are some research studies out there that are promoting the use of laser, showing some increased tissue repair. One of the things we can use laser for is wound healing. And one of the things that I used laser for when I saw it in the clinic was on our patients following like knee replacements or any major type of surgery. We could just take the laser and kind of go along the incision to try to speed up the healing of that incision. So things like skin ulcerations, surgical incisions, burns, light therapy can help with that. The helium-neon lasers, again, those are probably the ones with the lower output, are less effective in destroying bacteria. So if you have an infected wound, this isn't necessarily going to help with that, but may help to close it up a little faster. The healing process is increased by increasing phagocytic activity. So remember what phagocytes are. They are a type of white blood cell. They're the ones that kind of come in, help clean up the mess a little bit. So it's sort of moving us along from that inflammation to proliferation stage a little bit more quickly. Again, we have increased ATP synthesis, will increase cellular metabolism in the area, releasing free radicals, which again all helps to speed up healing. Will increase in the fibroblasts that are being deposited, which is going to help with that collagen deposition and the healing tissue, and increase macrophage activity as well, another type of white blood cell. Blood and lymph circulation again is improved, which is going to promote the growth of granulation tissue, new capillaries, speeding along healing. And again, the big thing here is that we're having an increase in circulation without having thermal effects. Usually the number one way we're going to try to increase circulation to an area is to apply heat. right? We cause vasodilation, we increase local blood flow, but if we have an acute injury, we can't apply heat. So laser can be something that we can use over an area where we might not be able to use heat and still get some of the benefits like increased circulation. Laser has also been theorized to increase collagen content and tensile strength of those healing wounds. So they're healing faster and they're healing stronger by using some light therapy. Laser is also used clinically to reduce pain. So it can be used to treat either acute or chronic pain. It has been shown to reduce nerve conduction velocity and decrease muscle spasm. An interesting point I read in some of these studies was that it only reduces nerve conduction velocity on nerves when they're inflamed, when they're carrying that pain signal. On healthy nerves, it doesn't seem to have any sort of effect on nerve conduction velocity. So it can also cause a decrease in prostaglandin production, which is one of those enzymes that contributes to pain and inflammation as well. There was a latent period following treatment, meaning that, again, this wasn't an immediate pain relief. It took several hours for the patient to experience pain relief. Helium-Neon lasers have been shown to decrease trigger point sensitivity in patients with fibromyalgia, so this might be a treatment option for them where, again, it's typically hard to find things that are successful treatments for them. So this could mean using a laser treatment over a trigger point to decrease that to then be able to treat it. Gallium aluminum arsenide layers, which are sort of the most powerful type of lasers, have been shown to decrease pain and increase function following 10 days of treatment where they were treated 5 days a week for 2 weeks. So a daily treatment, basically, with a 2 joule or 1 minute treatment at each tender point. They are looking at using laser for fracture healing, which would be similar to those implanted bone growth stimulators that we talked about back with eStim. This is still pretty early on. They're still using animal studies only for this. But the idea and the thought is there that this might help with bone healing as well. Some of the ideas are that it will help with increasing capillary formation, increase calcium deposition, which increases the callus formation, and reduce hematoma in the area. There are also theories that the photons, the light that strikes the tissue, may create some microcurrents that are, again, similar to those ultrasonic bone growth stimulators. So they have seen a more dense callus being formed by using laser, but no improvement in tensile strength has been noted. So it's not necessarily stronger because it's more dense. They also theorize that it may help to improve bony fixation to titanium implants. So following like your joint replacements and things like that, where there are implants, this may help to heal those faster. So contraindications and precautions. This part kind of cracks me up because of all the modalities that we've talked about. There are these huge long lists of contraindications and precautions. And here we are with laser, where you have to wear protective goggles and things like that. And this is probably our shortest list. So we're never going to laser over the eyes. We're never going to laser over cancerous areas. One that isn't listed here, but we will talk about it a little bit later, but I would probably still add it to this list, is pregnancy. Again, we just don't know exactly what it might do, but we're not going to take any chances. One big thing to take note of is that pacemakers are not on this list. So you can actually perform a laser treatment on someone who has a pacemaker. Precautions, the big thing with both of these lists, or both of these things on the precaution list, certain medications that cause increased sensitivity to sunlight, it's just going to cause the laser to be absorbed more readily and potentially cause more changes than we want to have happen. And over tattoos, again, because of the different pigments that are there, especially like the darker tattoos, black tattoos, they're going to absorb photons much more readily than the skin and surrounding areas. So we could have some uneven distribution of absorption there. So lastly, I want to go into a very specific type of light therapy. It's called anodyne therapy. It uses infrared light. It's also called monochromatic infrared photothermal energy, or MIRE. It increases circulation and decreases pain. Where this began and where it really gained its popularity was with our diabetic neuropathy population. So again, with this, just like with other types of lasers, we're able to increase circulation without the thermal effects. Now, some of these numbers here, I'm not exactly sure who did these studies. It could have been the creator of the machine, but huge increases in circulation. So that's the big thing. An analysis of 5 studies with over 5,000 subjects reported a 67% decrease in pain as well. So we're increasing circulation, we're reducing pain. Again, this was designed for patients with diabetic neuropathy. So Anodyne works by emitting infrared light from diode pads. I have pictures at the end here, and I'll show you how all this works and explain it a little bit. The pads are placed directly on the patient's skin in certain sort of configurations. Energy is still absorbed by hemoglobin, which causes proliferation of nitric oxide, dilates the blood vessels, improves blood flow. It also stimulates fibroblasts and osteoblasts, so assists in healing, significant increases in circulation, and also reducing pain. So typically when you use this with patients with diabetic neuropathy, they'll report a reduction in pain first, and then we start to see functional gains. It usually takes about a month or so of treatment, 4 weeks. Patients can be seen up to daily, at least usually 3 times a week, if not 5 times a week, for a steady period of time. And then we'll start to see some functional gains as well, like improved balance, improved sensation to the feet. And that's typically what we use it for. So again, this was originally developed for the treatment of diabetic neuropathy. Once we realized that it works for that and why it's working, that it's increasing circulation, we as therapists are trying it out on other things. So it has been FDA approved for diabetic neuropathy. It hasn't necessarily been FDA approved for all these other things. But clinically, we've seen it be successful in treatment of wounds, arthritis, poor gait and balance, usually due to loss of sensation, chronic sprains and strains, carpal tunnel, TMJ, things like that. So again, here's the contraindications: overactive malignancy or cancer, over or near the womb of a pregnant woman, which is why I think that should probably be on the laser list as well, and over topical heating agents such as Bengay, Icy Hot. Again, it affects the absorption of the light energy. And some potential side effects could be some superficial burns or even hypoglycemia, again, because of the changes in circulation. Anodyne and laser can be used over metal implants, pins, and screws, and can also be safely used with patients with pacemakers and defibrillators. So again, there's not a lot of contraindications to these. So this is what an Anodyne machine looks like. It's basically like an Easton machine. It's got 4 leads that come out, and each lead branches into 2, so similar to our electrode leads. These are what the diode pads look like, and this picture is just to show you that they are pliable, that they'll sort of bend around whatever body part it is that you're going to apply it. This would be a typical setup for diabetic neuropathy. I actually usually put 2 electrodes on the bottom of the foot. I ran one across the metatarsal heads and then use the other one up through the arch. These aren't adhesive, so you do have to use Velcro straps to hold everything in place. The other 2 pads then always go up on the calf. This is just a picture showing how they can be applied for treatment of TMJ. And this is just a picture showing that it's being applied with a metal or external fixator. So there's actually exposed metal, and they're still able to safely apply Anodyne with that. These treatments are longer. So typical treatment is 20 to 40 minutes. It can be applied daily. So like I said, I did see some patients 5 days a week to apply Anodyne, but resolution of symptoms generally takes about 30 days. The problem with this is, again, once you get the person feeling better, we start getting them functioning better. They usually end up being discharged then because they have benefited from therapy. They've typically met their goals for therapy. And then the problem is they stop using the Anodyne therapy, and then their symptoms gradually start to return. So I don't know if they still do, but they did have home units that they could rent to continue with treatment on their own. We'll get into billing eventually here, but in general, laser does not have its own CPT code yet, so we can't bill for laser. We did used to use some light therapy way back in the day, like infrared therapy and UV therapy. And so there is a code for light therapy, and that's typically what we use if we're billing for laser. It does not reimburse very well at all. So if a person comes in and spends 30 minutes getting a light therapy treatment, you're not going to get reimbursed very much for that. So the idea is that this is to be an adjunct to therapy. And so if they're coming in for like an anodyne treatment because they have diabetic neuropathy, we should probably be doing some balance and gait training with that person as well, because obviously they need it. So this should be combined with other treatments as well. If you're doing a typical laser therapy treatment or low light therapy treatment, those usually go a little bit quicker. Like I said, I'll show you on the machine. We can set a treatment up. We just can't actually do one. But the treatment setups are going to be similar to ultrasound, but there's no mess. So they typically go a bit quicker than ultrasound as well. All right, so that's it. Like I said, I'll show you some of this on the machine when we get into lab, so that you can kind of see what it looks like. And if you have any questions, let me know. Thanks.